not how we run the servers. Yeah. We all practice booting medicine here.
Trying. I'm still actually I might have a friend.
All right, everyone. It is my distinct pleasure to introduce Donovan Weed to you guys. Probably doesn't need much introduction to most of the room, but for some of our newer members, Donovan has been the MIS fellow at the University of Virginia here for the last year. Donovan actually did his undergrad studies here at the University of Virginia, then went to Chicago for medical school, and then residency in New York City, where he got extensive experience. Brought that to fellowship here. He's been a great fellow, a great partner, has taken on some of the most challenging cases, as we discussed already this morning. And I'm looking forward to his grand rounds talk. Donovan.
Good morning. As you know, I'm Donovan. I'm the MS fellow this year, and I guess it's my turn to do grand rounds. I didn't realize I had to do one when I started fellowship, but here we go. I'll try to speak slowly so people can actually understand what I'm saying, and then burn my time because I need to finish in 45 minutes or so. So as an MS fellow, I feel obligated to talk about bariatrics, robotic surgery, or AI. I feel like the latter points have been discussed pretty well in the last couple of years by previous fellows and chief residents. So today I wanted to talk about something more generalizable to all of us in medicine and not necessarily particularly to surgery. So I titled my talk, Conflicting Dr. Google. I have no relevant financial disclosures, not even stock options. And also I don't plan to be an expert here in this topic. I'm not going to provide a lot of evidence-based medicine or anything like that. It's just more of a discussion and have a little bit more fun here. So where we are today, gone are the days where patients first stop regarding a medical problem is a physician or a primary care provider. Now their first stop is online, which they consult the colloquially named Dr. Google. Patients want instant answers, and honestly, this is what many of our first encounters already look like and will continue to be. So my objectives today are to explore and understand and discuss the implications of Dr. Google in our patients' lives. I'll explore how and why patients use online search engines for health advice, understand the risk of online health advice, especially in the era of AI, and discuss strategies to work with patients in the new digital landscape. So a little history about where Dr. Google came from. The term Dr. Google popped up in the early 2000s with the boom of the internet. By the early 2010s, this doctor was widely referenced in medical literature and mainstream media, such that in 2012, the American Medical Association published a ethics article on this very issue. And I think where this came up from is that at the time, about maybe 80% of Americans were using Google for a primary search engine. The other 20% were using things like Yahoo, Bing. If you remember, AskJeeves.com or something like that. This article here highlights the ethics of using Dr. Google and how it created an ease of access for patients, the shift in how we educate patients, and how physicians were evolving into guides for patients as opposed to the gatekeepers of medical information. So why am I talking about this now, nearly almost a decade and a half later, is that it has clearly been integrated in our everyday healthcare. I have here a survey reference from 2024 of 2,000 Americans, and it shows that about 80% of people who responded to the survey chose self-assessment methods over seeking professional health care when they felt unwell. Over 50% of them were convinced they had a certain diagnosis based off their Google search, and a quarter were starting to use more advanced search queries using AI for health-related inquiries. And as you can see, the internet has well integrated in how we offer healthcare. So this is a breakdown of why those people who responded to that survey turned to Google for health advice. A large proportion of those patients wanted quick answers or out of curiosity for certain issues. You can see about 50% wanted to be informed before seeing doctor, some wanted a second opinion, and there's a good segment of patients who have a mistrust of medical professionals, which is concerning. Although a large number of patients often find useful health-related information on the web, about half of these patients also responded they felt overwhelmed by the amount of information they're encountering. And furthermore, younger generations will have a higher tendency to trust online information, particularly those from popularized mainstream and social media. And this is also part of that same article, that same survey. And this looked at what people were searching for across the globe at the map of the United States. And if you can see here, if anyone's curious, Virginia is not only for lovers, it's for insomniacs. So the modern patient here is comes in 3 flavors, I think. There are the ones who are anxious Googlers, the self-diagnosers, and second guessers. The anxious who are, have basic symptoms and go down a deep dark dive and get oftentimes overwhelmed by information and diagnose themselves with catastrophic diagnoses. There's a confident one who is already convinced of what they want and they're just looking for information to back up what they believe to be true. And the second guesser is kind of a mix of those two, but comes in 2 flavors, but have an inherent distrust in providers and healthcare systems. And they seek to look for answers on the internet with a heavy reliance on information they already believe to be true. So this is a short article, a short video from the HBO series The Pit. Actually, when I first saw this, I was like, okay, I can get my talk based off of this, and have something interesting to talk about.
The measles got to his brain?
Well, his head CT was normal, but the only way to find out if he's okay is to perform a lumbar puncture.
A spinal tap?
I've read about kids who've been paralyzed from a spinal tap.
There is 0 risk of paralysis.
What about bleeding or infection?
It's a perfectly safe procedure. We do it every day.
We need spinal fluid to see if Flynn has acute disseminated encephalomyelitis.
And if he does, we treat with high-dose steroids to decrease the risk of blindness, deafness, intellectual disability, even death.
He could die from this. The death rate from ATEM is high, 1 in 5.
Do the spinal tap.
No! Can't you just give him steroids without the spinal tap?
If there's no ATEM, the steroids could suppress his immune system, making it harder to fight off the pneumonia.
But it says here
Can
that...
you put your damn phone away? Your son is critically ill. The longer that we wait, the higher the risk of permanent brain damage. What is not clear here?
Hillary, he has a tube down his throat.
They're
Can't
not
breathe on his throat.
poking holes in my son's spine.
Wow.
Let's just wait and see if he gets better.
Dr. King, could you please take Flynn's parents to see their daughter?
No problem.
They are going to see their daughter.
Fucking Dr. Google bullshit. They want medical treatment, but they don't want medical advice. What the actual fuck are we doing?
Yeah, I know, and we'll keep trying.
The measles.
So punchline there, right? Anyhow, so the main takeaway is that we're no longer gatekeepers of medical knowledge. We are guides now, and we're here now to help patients to interpret the flood of information they get online in a way that's safe, reasonable, and actionable. So the modern patient journey starts from symptoms and then finally getting to the hospital. No matter how vague they are, most patients will inevitably and realistically look towards the internet and diagnose themselves with a number of disease processes. Patients then use their own judgment to search for answers, research what they can possibly have, and maybe even self-treat. And oftentimes these treatments are in a manner that suits their own goals and may not be necessarily what they need for the disease process. And after all of that, then they finally may present to you. So realistically, patients are well informed, right? Because they have all this information, not necessarily true. So when consulting the internet, there are a couple caveats to consider, as the search algorithm is quite complex, and the refinement of search results, particularly towards healthcare-related topics, are less prone to things like sponsored ads and specific recommendations. In other words, they keep it vague. Often, health-related inquiries direct to websites such as Medline, Mayo Clinic, WebMD. So overall, not a horrible way to start a medical inquiry. But there are other factors that can affect a search result. context, and how patients input questions are primary drivers of the quality of the results that they get. User metrics such as what the patients have searched for in the past, geography, and top searches also play a role in skew results. Good intentions don't always equal good information. So some of the issues I'm going to talk about when patients search things online are misinformation, lack of clinical context, development of health anxiety, bias in results and how we search for online topics, privacy concerns, and the undermining of trust between healthcare teams and the patient. So first I'm going to talk about misinformation. So large language models is now a lot of what we look towards in AI and how we search for things. The errors do occur with these systems, although not as frequently as they did in their early inception. Something that can happen is called AI hallucination, is when these large language models, which power AI, generate false, incorrect, and misleading information. And oftentimes they'll make up citations that may not be necessarily true. And these often occur in settings where the discussion topics are more complex, the input that is put into the system is vague, and the data that these language models are built on are biased or incomplete data sets. And so this kind of works in a number of different ways as well, that how we get information from the internet can be very complex. A very common phenomenon that can actually impact online search results is trending content. How this works is that content with high traffic has increased scores that will generate related websites, titles, and even things that are considered clickbait. These sites continue to develop high traffic scores and become popularized and can drastically affect its presence in social media and even into mainstream media. This is how myths go viral online. It's a very busy slide, but it's just saying pretty much the same thing. The other thing we'll talk about is lack of clinical context. Without clinical context, search engines can't give reliable answers. Good searches depend on good prompts, and patients don't always know how to ask those things. So for instance, I'm going to start with a simple question. It's why am I feeling nauseated, right? So you can consult the internet about why you have nausea, but without medical knowledge of clinical cues, medications that patients may be on, response may be very limited and can only discuss or provide information in very broad speaking terms. If we add a prompt like, why does my groin hurt? The response, again, very broad, and you can be diagnosed with things like muscle strain, joint problems, a hernia, torsion. And as we link these key symptoms together, we can develop a more focused understanding of what's going on with this patient. But again, these are very limited solely based on what patients want to ask into the search engine. So if you combine those questions, maybe you have a better understanding of what's going on. Often, many of you can probably diagnose and figure out what's going on with this particular query. Is maybe they have a bowel obstruction from an inguinal hernia, right? But then, even if they land on hernia, they may keep searching for ways to avoid surgery. All right, so this could possibly lead to danger because it totally depends on what you put into the search engine. So if you look at the result that you get, it answers your question. You have nausea, your hernia hurts. What should you do to avoid surgery? It gives you things to do to avoid surgery. Right? It answers your question, but it may not be in a way that is meaningful to you as the patient that is treating the actual disease process. There's a little itty bitty caveat that says it's crucial to seek medical advice and proper diagnosis and discuss your options, as some hernias may require immediate surgical intervention. Right? That little tiny box. Let's look at another one. We look at another result, same question. I'm having nausea, my hernia hurts. What can I do to avoid surgery? Well, very empathetic, right? I'm very sorry you feel that way. But as a quick overview, it does do a better job at saying, hey, you should probably seek medical attention if these are your symptoms, and you can avoid surgery, but it's maybe temporary only. And again, it answers your question, right? And then we'll do one more. Non-surgical ways to relieve hernia pain. Again, they answer your question, your home remedies, treat the nausea, some tea, right? That'll fix your hernia, right? But then it gives a little bit of a warning box that says when to seek medical attention. So again, it answers your question, but you had to frame it and you had to actually read through everything to get to the point where you may need to seek surgical or medical advice. So next we'll talk about health anxiety or hypochondria. And health anxiety with online search is a very prevalent obstacle in patient care. For me, just going through medical school, I think I diagnosed myself with 5 different things, right? So now imagine patients with just as much access to medical information as we do, there's a high risk that they get overwhelmed. More information, more anxiety. So if you do a simple search or abdominal pain, you get 20 possible diagnoses. No wonder people panic, right? You can have constipation, gas, food poisoning, you can have appendicitis, you can have surgery from a hernia. There's a whole list of things that pop up when you just say, I have abdominal pain. There's no clinical context. Look at this, you get overwhelmed, and oftentimes develop a certain degree of healthcare anxiety. Furthermore, if you look at certain search results, they conveniently link to well-known medical institutions which validate how we self-diagnose. Results such as Cleveland Clinic, Mayo Clinic, Medline, etc. These are trusted sources that give search results authority, making patients feel validated even though they may be looking down the wrong path. And then this was just another one of the AI systems I looked at is this, why do I have abdominal pain? This one happened to be in link with the previous question and ask regarding my nausea and hernia pain. And it gives a good breakdown of that, but it doesn't also statement here, it says a general breakdown possibilities, but it's not a diagnosis. Okay, so nice little caveat there, but again, depends on how much patients read into those particular nuances. Let's skip this. So next I'm talking about bias. So bias comes in multiple different ways. There are patient bias, such as popular bias, recency bias, and confirmation bias. Additionally, data bias exists. Biased sampling, training, and prejudice built into the program can ultimately skew search results. Machine learning is only as good as its training material, and it relies on a certain volume of data to train itself to create reliable output. But if the data is inherently flawed, then so will the output. So one of the confirmation bias things I'm going to talk about is how we interact with medicine based off of what we're currently experiencing. If you're looking for a problem, you can often find a problem to validate yourself. Then we have nausea in the setting of incarcerated hernia, but also start a new medication for reflux, right? It's not uncommon to simply look for the newest thing that says this is the cause of all my problems. I'm having nausea because I started omeprazole because of my abdominal pain, right? And then patients will inherently stop taking the prescribed medication, look for simple solutions for potentially complex problems, and find validation in answers that may not be correct. Next thing we'll talk about is privacy. There needs to be a balance between de-identification in healthcare organizations while maintaining public and personal security. Deep learning requires data which can inherently develop bias. And there are a number of concerns regarding maintaining privacy in this ever-growing sector. We looked at the ethicists in cybersecurity to better understand the broad implication. And this is actually a major topic with AI and ethics that was the keynote for SAGES this year. But a key takeaway is that with all these concerns, how does this affect our patients? An article was published out of utilizing data from the College of Information at Texas, which looked deeply into this particular privacy concern in AI-driven healthcare. We should understand that there are severe limitations in the consensus of how we treat healthcare information. Regulations often fall behind developing technology. Search engines and large language models can often store and use data without our knowledge, because who reads the fine print? This data can be used to train AI and create an imbalance in what information patients can and will provide. We further this bias that we had previously mentioned. And then I think lastly, HIPAA compliance may not be held to the same standard. Health apps are, as opposed to healthcare companies, may have different predetermined agreements, and much of our health information may in fact be public. Just a bunch of new articles that came up by that same topic. All right. So to a patient, Google, WebMD, AI systems, etc., offer a polished, authoritative sending answers. Responses tend to be instant and well summarized, which seem a breeze compared to the at minimum 15-minute clinic visit. We as clinicians become constrained by time, ethical nuances, and complex considerations that now we, the experts, sound less convincing than we should be, even though we may be right. These search algorithms make patients feel like they've seen everything, but that's often an illusion. Results tend to prioritize popular content and do not necessarily address the patient's specific nuances and medical complexity. Good medicine is full of gray zone, and the answers may not be so clear cut. When we don't always agree with the search result, we can appear dismissive or even incompetent in comparison. Ultimately, as more and more patients bring their search results to us, our role as physicians become a validator and our recommendations become less authoritative. Ultimately, if we agree with what patients have researched on their own, we reinforce their behavior. And if we disagree, we invite skepticism. Either way, our patient-doctor relationship erodes. So I talked a lot about risks associated with how patients can interact with the internet, misinformation, lack of clinical context, developing health anxiety and information overload, etc. So I'll finish my talk now with a few strategies that clinicians can use to work with patients. So patients are now in your clinic. They have already consulted Dr. Google and they have their own mental plan in mind of how they're going to treat themselves. Oftentimes, they will also come with information overload, have partial information, may not understand everything that they have read, and they may also even be confused by conflicting articles and evidence. So it's not unusual that patients have information overload. This here is a chart of the number of open access journals in the medical publishing industry over the last 2 decades. As you can see, there's an exponential increase in the number of open access journals, which contribute to the over 1 million publications per year that are published to these journals. Many times, a simple Google search, we can come up with some pretty unusual spots. Add to that the growth of open access, and patients are bound to drown themselves in a sea of information. With all of these access and medical publications, are we also diluting medical information? That's a concern as well. And this article I read published last year, and the conclusion is maybe, because there's such a big impetus for people to publish that these peer review of articles may not be as fine-tuned. The number of open access journals that are pushing the cost onto the authors as opposed to the readers really want them to push more and more articles so that we're publishing, I think, 1.4 million articles as of last year of new medical journals. I mean, new medical articles in journals, that's like 1.4 million as opposed to previous years was like, I think last 2 years were about 1 million or so. A lot of information, right? But how much of that is actually understood? So another consideration is how much of online information do patients understand? Health literacy strongly correlates to patient outcomes. Low literacy rate has strong correlation to more ER visits, more complications, reduced preventive and health screening services, and ultimately worsened outcomes. And the average reading level in the United States is at the 7th grade level. So on average, our patients are about 12 to 13-year-olds. These patients have an increased risk for struggling with how they can be cared for and how they make choices that affect their quality of life. A key systemic issue becomes how we bridge this disparity and how we facilitate communication between patients and providers when more and more patients are visiting online information first. If we look at the average reading level of high-impact medical journals, we can expect that a large number of our patients will, by and large, not understand the content or the entirety of the content. They look at the headline, right? The average reading level of these journals is at the college level. Inevitably, the average patient will rely on summarizations, community thread headlines for their needs. A growing outlet has been also that popular in social media are dictating how patients take care of themselves. And if we look at topics like medicines that we don't understand, disease processes are continuously being investigated and finding new and better medications to manage disease processes. Journal articles are published all the time, which may have opposing views and results with varying levels of reproducibility. This is how we develop a better understanding of science, by challenging convention and constantly reassessing our impact in our care. But patients don't necessarily see that. They see mixed messages and say that doctors don't know what they're doing. Just a simple example, some patients will see results that they want to find too, right? So this is 2 different articles that looked at how proton pump inhibitors have an increased risk of dementia. One says, yeah, sure, there's a correlation there. And one says that there's no risk at all, right? And these are from, I don't remember. nature is the second one, but if we as medical community don't agree on something, how do we expect to consider patients of our recommendations, right? So the clinical strategies for taking care of these patients can be challenging. To get through to patients in a meaningful way in a 15 or 30-minute clinical visit can be extremely challenging. Thankfully, we have residents. Yeah. So what can we do? We can listen empathetically. We can explain and clarify limitations of online searches, search engines, AI. We can recommend reliable sources for our patients, and we can develop and reinforce shared decision-making with our patients. So we took a page from psychiatry because they deal with the most extreme of these patients who are hypochondriacs with a healthy dose of anxiety. Here they offer clinical pearls and strategies on ways to control and help manage something that is quite frankly a addiction for many. So this is a very busy slide, but I broke down the articles and on 6 themes that help generate ways that we can interact with our patients. The first is patient competency and behavior to assess whether patients can make sound decision making and based off of what they search online. Here we identify competency in patients and identify how they develop clear expectations of their online searches. Next, we also evaluate the medical information that they have searched. This is where we look at patients where they're finding their sources and understand information that is not, and that information may not be the same as understanding. Third, we manage information overload where we encourage shifting towards consistent consistent sources and shying away from unproductive searching. Fourth, we discuss options with thorough risk, benefits, and feasibility on how we can actually treat these patients and compare those treatment choices with things that patients have found. Fifth, we address uncertainty when we teach strategies to handle ambiguous content that they find online. This allows us to help patients understand and tolerate inconsistencies in healthcare guidelines. And then lastly, we develop a shared clinical decision where we leverage patient-physician rapport and reinforce how we support ourselves with online sources that does not necessarily replace clinical judgment. So this is a fun one. This is an article that talks about how to Google in front of the patient, right? So the patient's there, like, oh, I'm gonna Google something real quick, right? How to do this in front of the patient. So this breaks it down to a few steps, and a lot of it has to do with how well you communicate with your patient and how well you can be engaged in a shared decision-making model. We first set up a space, prepare the space, and allow our patients to know that this is what we're doing and show them this is what we're looking for. We have established trust and communicate with the patient as an active listener, and then we search together. We want to clarify with patients how you are finding information and how we ourselves are searching for information to help contribute to their overall healthcare. Lastly, we use reliable sources to reinforce what we know to be true and establish our own limitations. It's okay to say that we don't know everything sometimes, and this is how you really develop rapport with your patients. And then for things that you don't understand and don't know yourself, we can often set up expectations for a subsequent visit. The opportunities ahead in this space is very abundant. AI and online sources can continue to support clinicians in many ways. They help us triage patients, offer pre-education for patients that allow them to ask more meaningful questions, and enhance their communication with their patients to develop future treatment plans. The last thing I look at here is man versus machine. This is a busy slide, but I think this came out of UVA, right? Some of you may recognize this article, and it looked at 50 physicians using conventional resources versus AI resources to develop a diagnosis based on clinical vignettes. So the step 3 clinical vignette kind of questions, this is similar to that. Again, it's 50 physicians, both attendings and residents, medicine, not surgery, but still. It looked at how they performed in diagnosing those particular vignettes using AI versus conventional resources alone. And there was no difference. Their accuracy and diagnosis rate was 72 to 76%. And that was stratified based off of experience using large language models and without experience using large language models. But again, those physician groups, there was no difference between how we integrated with conventional resources and AI resources. They did a subgroup analysis that also looked at how those AI systems did alone. And AI systems were diagnostic, had a diagnostic accuracy closer to 92%. So maybe AI is better than us, right? But again, these are clinical prompts, not necessarily real patient care. So just something to think about. And that's all I have.
No, that was a very interesting, wonderful talk about a controversial topic. And one of the things I think we need to remember is, 150 years ago, the medical profession didn't have very much to offer. We had no medicines, we had no knowledge. We, in fact, sometimes did harmful things to patients. But what we did do is we were there. We were there and we cared for patients in difficult times of birth, death, sickness. And that's why our profession has continued to survive. And I just want to, all the residents in the audience and the students, when you see a patient, your encounter should involve patient care, with emphasis on care. We all have the information and hopefully we'll apply the appropriate tools that we have and information that we have to help them. But it's not going to be as good as unless we had the care. Thanks for emphasizing that for us.
Me? Okay, so as an AI researcher, let me just play devil's advocate and defend Dr. Google for a second, because I think the most powerful slide of your talk was the second one, where 1 in 4 in our general population are using large language models to figure out what is the next step and what to do. And that tells us that our reaction to this phenomenon, because it's happening no matter what we do on a microscopic or an institutional level, is to understand how we can control the narrative. We're at a cusp of informational, like dissemination, like the information asymmetry in medicine is like no longer really an issue. Yeah, there are issues related to health literacy and all that stuff that you mentioned, but it's out there and it's available. And I think what I would kind of encourage our, next innovative thinkers and the audience to think about is really how can we as clinicians help harness and control this phenomenon so that our patient population don't get information overload with bad sources. I mean, the corpus of medical literature that these large language models are utilizing is very expansive, but our lab has a partnership with School of Data Science, and we're developing large language models using RAG models, et cetera, that can control the literature or the body of literature from which these AI tools extract them, so that we can relieve, our administrative support staff with, inundated questions of like, when can I use my Colace, right? Like there are ways that we can actually leverage this phenomenon to our advantage. And so I just want to encourage us not to be too adversarial with the innovation, the technology that's happening, but really ask ourselves, how can we actually leverage this to our advantage and take control of the narrative?
I think that's a great idea. And my husband is all in the chat GPT and he talks to it, right? She's named Evelyn and he'll ask her questions, he'll have conversations, and like it is incredible. Like the intonation of her voice, she sounds totally real. And like that is a perfect example, thinking about our nurses and the amount of time they spend on the phone. It's just, I've never thought about that, but that would be, a perfect thing. Now, I don't know what the risk liability there would be. That's
Evelyn.
Evelyn's never been sued before, though.
Well, speaking from the nursing side and the phone calls that come in from patients, a lot of them have already literally diagnose what they think they have and what they need to see Dr. Shen for, and they know what they want, and they'll call and say, tell Dr. Hallowell I need another EGD or whatever, and yes, they do have in their mind what they want you to do for them, based on what they looked at.
My thoughts, so just listening to this too, is yes, it's going to be on a grander scale, but I don't think this is the new phenomenon, right? So, and what do I mean by that? I had a woman in my office the other day where a doctor had told her, you have a cerebral vascular and you need to go see him, he's going to fix you. And there was no evidence that she had a volvulus or cerebral vascular. And so I had to deal with all of that misinformation. And that came from a doctor, right? And so I do think these phenomenons of misinformation is not new, right? And some of it is, I think what happens in these office settings is, doctors get a little bit overwhelmed. They just want to get rid of this person, right? So they say, go see Donovan, he'll fix you. You got a hernia. And then you go see you and you say, well, I don't really think you have a hernia. And then there's a whole distrust of that. Well, Dr. Friel said I had a hernia, and you're saying, well, he's an idiot, right? So it's not new, but it is the scale is much more massive. So, but just like we had to manage that phenomenon, we're going to have to manage this phenomenon because there is probably a lot of upside in this. And we're going to have to figure it out. I love my AI thing in clinic right now. It's unbelievable in clinic. I think it's great.
I was under the buddy is doctor told me about a AI program that I think it's through either Mass General or the Brig or something, where basically it's developed by them that is maybe a little bit more, I guess, curated or more trustworthy, or they have has to have a higher level of confidence before it gives a reply. And he said that he uses it all the time. Do you have any experience with using, I'm pretty sure it's like a proprietary
There's one that's
thing.
semi-free for like a couple of queries. I was trying to avoid specific names in my talk, but when I use more often, it's called open evidence.
Yeah.
And that directly pulls from PubMed for journal articles from their source citations. Yes.
Yeah, and this may be more a question for Tom, but I'm curious after this talk and our talk at M&M. Would the data set in AI be able to evaluate the data and tell you that a certain study is junk or is based not on the correct data set, or what Tracy brought up, diverting loop ileostomy? The headline is you put things back together, and what people take away from that is I don't need an ostomy. Yet half the patients in the study had an ostomy. Can that be corrected, or can we really dig in and get the answer? Is contrast in IV contrast in critically ill patients? When should we use it? When should we not use it?
Yeah. So I think it'll do a better job than we can because of how much information it can pull from.
So, if you go on open evidence, you can type that in and it will give you a summary. It will give you the citations. And those citations are truly, so the RAG model that open evidence is based off of is from a corpus of literature off of PubMed. So it is technically like that, like peer-reviewed journals. And then depending on partnerships and metrics that they internally use with their own proprietary algorithm, they'll tell you like, okay, this is a leading journal. Oh, this is a high impact factor. And this is not, et cetera. Now, it's a black box from our perspective. We have no idea, like Steven's just like texting me about biases because open evidence just partnered with New England Journal. So any NEGM article that's cited through open evidence, you have direct access to the entire thing, regardless of your institution subscription relationship with them. So there's now an introduction of implicit bias into this as well. So, I mean, short answer is yeah, it's a great tool. All of you guys, all of the trainees should definitely use it, but with the caveat that it's just a tool. It's strictly a tool. It's not absolute ground truth. Like if you just need to quickly ask a question and get some direction as to where to find the literature and what, it's actually very useful. But in the wrong hands or in the lack of medical expertise, it could be very dangerous though.
But again, is that any different than what we do now? I mean, I read one article and I'm biased, and so it's just a different version of the same
No,
story.
it's just that-
So you agree, it's a tool, but so is searching PubMed and me reading them by myself and coming to a conclusion and taking an action.
Yes, 100%. But there is a difference between Googling, 30-day postoperative outcomes after, primary versus, I don't know, like a suture versus staple, ileocolic anastomosis on PubMed versus asking the large language model that, which it will filter literally all 5,000 hits that you would get through PubMed, rank it for you this way, give you he didn't show it to you in this slide, but there's a nice blurb that comes up. It's like a nice, maybe 7-sentence summary with citation. And then the citations will pull, the ASCRS guideline, the, newest, I don't know, like JAMA surgery, article. And so it does make your life easier parsing through all the information. But you're right, at the core of it, AI is nowhere near, or ever really will, in my personal opinion, replace human intelligence. It's just a smarter tool for us to use.
How many of the new articles are being written by AI?
I mean, these are all, these are 2014, 2018, but nowadays I think probably a decent number of journal articles, given the millions of publications we're doing a year, will have a significant AI.
I want to know what Noah Wiley's patient satisfaction surveys are, because that guy, I wish I could say what he said. Once. Get away
They're
with
not good if you watch the show. They bring it up, the patient says it, they're not good.
Ready? Yeah, with that approach.
Maybe on your last day.
I do have the. You told me I was